Hello, everyone. Thank you so much for coming to our webinar today. I am going to share my screen so that we can go ahead and begin with the presentation. And today's lecture is Refraction in the Real World, Tips and Tricks for Refracting Your Patients. I'm Dr. Caroline Marhefka, an optometrist, and I specialize in pediatric optometry. I completed my residency in pediatrics at the New England College of Optometry and went on to join as faculty, where I am now an assistant professor at the New England College of Optometry. And I'm very excited to share my tips and tricks for refracting patients, as I've not only had to refract adults, but learn how to do it in pediatric patients as well. Here is a copyright notice for your review. Today we will be discussing the art of refraction, and it truly is an art form. It has very unique modifications for every patient, despite having a general standardized procedure. We're going to be discussing both subjective and objective refraction techniques and look at the multiple tools that we can use to determine a patient's refractive error. The key to refraction is realizing that you are in charge of the refraction. It is not what the patient says, although they are a key part and a great tool to use with their subjective responses. But ultimately, you are the doctor in charge of the glasses prescription. Keep in mind, it is just that, a prescription. It's something that you have the final say in determining so that it best fits the needs for your patient. Today's objectives will be to review subjective and objective measures of refraction. We will be discussing how to perform retinoscopy in a clinical setting. We will determine how to calculate the net retinoscopy finding. We'll be outlining the procedure of manifest refraction and exploring clinical pearls for refraction in a clinical setting. For the purposes of this lecture, keep in mind we will be working in minus cylinder for refractive purposes. If you are more comfortable with plus cylinder, you can easily transpose. We call it combine, change the sign, and rotate by combining the sphere and the cylinder powers, changing the sign of the cylinder, and rotating the axis 90 degrees. Our methods of refraction are both subjective and objective. Our subjective methods include our manifest refraction, where the patient sits behind the phoropter and gives us responses based on which options appear more clear to them. And we can also perform subjective refraction in a trial frame that can be placed on a patient in any setting if they're not able to be placed behind the phoropter, and we can refract them through the trial frame itself by alternating the lenses. Objective measures include our autorefractor in addition to retinoscopy. Retinoscopy is an excellent tool for patients who may not be able to sit behind the phoropter or are not able to give us reliable subjective responses. First, we will be looking at the objective refraction called retinoscopy. Our goal of retinoscopy is to objectively neutralize a patient's refractive error. The key here is that it's done objectively. Our patients do not need to give us feedback on this process. Consider a patient who comes in and you have no starting point for the refraction. Maybe they brought in an incorrect pair of glasses or a very outdated pair. Perhaps they gave you their near vision only glasses and didn't realize, so you have the incorrect one in the phoropter. You could do retinoscopy to get a more accurate starting point if you start to notice that your subjective refraction in the phoropter isn't going quite as planned. Consider pediatric patients who, one, cannot sit behind the phoropter just to limitations in their small body sizes, reliable responses, and also to remove that accommodative stimulus of the phoropter that we want to avoid in pediatric patients. Retinoscopy is a great tool for our nonverbal patients or any patients who may have autistic spectrum disorder, any patients unable to sit behind the phoropter due to mobility limitations, patients in wheelchairs or who may have physical or motor disabilities where they're unable to sit in your exam chair and unable to have that phoropter placed in front of their head for a long period of time. Retinoscopy is also great for vision screenings when we're not able to roll in the entire phoropter, and just to get an estimate of prescriptions and whether they should be referred for further eye evaluation. So how does retinoscopy reveal the patient's prescription? We have to consider both the image point and the far point when we're doing retinoscopy. Consider the image point as light that is coming into the system, where light rays are converging in the back of the eye. Our far point is the light going out of the system, or diverging rays from the retina. This is the location of the farthest object on which the fully relaxed eye is able to focus. Our retinoscope is at a set distance from infinity. We have to take a look at the eye's prescription, which is what we call the refractive error, and then put in lenses that we put in glasses, which is what we call the refractive correction. These lenses effectively neutralize the patient's refractive error so that light focuses at the correct spot on the retina. We use lenses to place that patient's far point at our retinoscope. Consider that you do have to remove the amount of lens power that's equivalent to our working distance, commonly 50 or 67 centimeters for most practitioners. There are three scenarios that may occur in each of our principal meridians. First is emmetropia. That's when our image point is at the retina and the far point is located at infinity. This is when no lenses are indicated for neutrality. You want to consider your working distance as well when scoping this with a retinoscope, as it will not appear neutral with no lenses in place because your working distance is at play. We can also have myopia, where the image points in front of the retina, causing our far point closer than infinity. Minus lenses will be needed to neutralize that refractive error. Final scenario is hyperopia, in which plus lenses are needed to neutralize the refractive error because that image point is behind the retina. Here is a photo of the retinoscope that can be used. You can see the front of the retinoscope where we're looking at the mirror, the handle with the battery installed. The back of the retinoscope is the portion that will be placed in front of the examiner's eye. You can see the brow rest that lines up with your eyebrow, the observer window where the examiner's eye looks through the peephole, and the sleeve or collar, which allows us to change between diverging or converging light rays. For the retinoscope, I would recommend keeping the sleeve down for diverging rays. Our retinoscopy reflex is evaluating light that's coming out of the system. This is moving the streak of the retinoscope across the patient's eye, which produces the movement of the patient's retinal reflex. One option is the width motion, which is when we move our retinoscope in a certain direction, and that reflex moves in the same direction. In this example, you can see that the reflex is moving to the left, just as the examiner is moving their streak to the left. This case is when we would want to add plus to neutralize. Another option is against motion, meaning that as we move our reflex in one direction, the examiner's scope goes the other way. So you can see here as the examiner moves their scope to the right, the reflex actually shifts the opposite direction to the left, creating an against motion. This is when we would want to add minus to neutralize the reflex. Our final option is a neutral reflex, which is essentially a full pupil. There's no with or against motion, and that is our endpoint when we've determined the correct lens to place in front of the eyes. You can see here as the examiner moves the streak, the pupil is fully illuminated. There's no motion, neither with nor against. Our lenses are added in front of the patient's eye until no movement is observed. This occurs when the lenses place the patient's far point at the retinoscope and is when we are able to plot that lens value that neutralizes the movement on our optical cross. We'll be starting our first poll question. This question asks, which patient would be the most appropriate to perform retinoscopy on for proper assessment of refractive error? This would be a 19-year-old patient with myopia and astigmatism, a 4-year-old patient who failed a vision screening at school, a 70-year-old patient who arrives to your office with a cane, or a 35-year-old patient with a history of optic neuritis. And we'll give you a few seconds to go ahead, submit your responses. Great. We have 83% agreeing that the 4-year-old patient who failed the vision screening at school would best benefit from retinoscopy. Our pediatric patients are incredible subjects for retinoscopy. It's very difficult to get accurate subjective responses from them, and retinoscopy following a cycloplegic refraction is the gold standard to get the best glasses prescription for our patients. We will go over the procedure of retinoscopy and multiple ways that we can do this. One is in our phoropter, where we use our sphere and cylinder dials to neutralize both meridians as we use our retinoscope. The phoropter would be placed in front of the patient's eyes. Another option, which I like to use for vision screenings and on pediatric patients, or those who again cannot have the phoropter placed directly in front of their eyes, are loose lens bars. We can see here that the red bar contains minus lenses and half diopter steps, ultimately going to full diopter steps once we get into the higher powers. Our black bar contains plus lenses, which we would use to neutralize the with motion. For example, if we saw with motion to start with no lenses in place, we would go ahead and grab that black retinoscopy bar and continue to add plus power until we get neutral or see reversal when against motion begins. And we know that we've gone too far and added too much of the with power. The procedure for retinoscopy starts by holding the retinoscope handle in your palm. You will use your index finger and place it on the retinoscopy sleeve, which can change the meridian. Ideally, you would want to have the the streak facing directly up vertically, but not every patient has an axis that's at the 180 or 90-degree meridian. So you want to have your finger ready to go to rotate the orientation of your beam to best fit the patient's true axis. You should be comfortable using both your dominant and non-dominant hand and eye. As you can see here, the examiner has her right eye in line with the patient's right eye, and the body is set to the left so that we're not blocking the patient. If she was to switch to do the left eye, she would actually have to hold the retinoscope in the left hand and hold it over the left eye so that she is now to the right of the patient and not blocking that central visual axis. My patient education here is that I'm going to be using my instrument to get an estimate of your glasses prescription. Please look at the letter behind me. Try to relax your eyes and let me know if I block you at any point in time. You will then proceed to turn off the exam room lighting so that you can appreciate the reflex more clearly. You will display a target. I recommend a 2400 letter as seen here. Other options include reverse contrast or a red-green screen. The examiner will then line up their right eye visual axis with the right eye visual axis of the patient, and they will use their preferred working distance. This can be either 50 or 67 centimeters. And I do recommend the reverse contrast. It's not shown up here. We have the standard contrast with the black letter and a white background. The reverse contrast really helps to limit glare as well. First, you'll look through the peephole of the retinoscope and check the patient's pupillary reflex. We will assume the primary meridian of 180 and 90 degrees for this example. And the examiner will place their brow on the scope and you will orient the beam vertically. You'll move your head and hand in a slight motion that allows the light to sweep across the pupil, and you would appreciate a horizontal movement of your scope. Once you've neutralized that meridian, we rotate our axis 90 degrees and proceed to sweep our light across the opposite meridian. Now we are moving in vertical movement, moving our head up and down slightly. And keep in mind, the meridian you're scoping is opposite of the direction of your light streak. When our beam is facing vertically and we are scoping side to side or horizontally, we are actually scoping the 180-degree meridian. You're scoping your vertical beam directly across that horizontal meridian. And vice versa, when we rotate it and our beam is facing horizontally, we're now scoping up and down along that 90-degree meridian. You then add the appropriate lenses, depending on whether you see with or against motion, that neutralizes each of the principal meridians. In the previous example, we had 180 and 90-degree meridians, so we had a perfectly vertical and a perfectly horizontal streak. This is not always the case if the patient has oblique cylinder or axis that's not exactly at 180 or 90. What you will notice is a break. So the break is the distance of which the reflex is misaligned with our streak beam. This causes skew, which is the motion of the reflex when it's misaligned with our streak beam. It's very difficult to appreciate. You notice this scissoring effect that is not a nice, clear beam. The brightness will also be dimmer. The margins will be less distinct when you're further away from the patient's true axis. You always want to make sure that our retinoscope streak is aligned with the patient's true axis and reflex. The width of the beam tends to get wider and less defined as well, the further away you are from the patient's true axis. I recommend using 3-eye technique for our retinoscopy. This is a technique that helps to control for accommodation. What you would do is initially perform retinoscopy on the patient's right eye, and you would neutralize both the primary meridians and place these on a power cross. Next, you'll perform retinoscopy on the patient's left eye. You'll neutralize both of those primary meridians. However, consider that when we perform retinoscopy on the right eye, no lenses were in place in front of that left eye. We had not essentially fogged or added plus to the patient due to the examiner's working distance, which if you have a 50-centimeter working distance, that is a 2 diopter working distance. So you would have 2 diopters in front of that left eye that are now in place. You want to go back to the right eye and make sure that you rescope and check that there's not any additional plus now that we've taken out that accommodative component in the left eye. Other ways to control for accommodation for our patient include using a large letter like the 2400 letter, keeping the lights low, reminding the patient to look at the letter, not to look at you, or to let you know if you block them at any point in time, and to ensure that both eyes are open. Try not to have your patient squinting one eye or the other. This is a chart that outlines how your retinoscopy procedure may look. In this case, we have a patient with spherical refractive error. You would start by surveying that reflex in both of your primary meridians. When you find with motion, you will add plus until neutrality. If you see against motion, you'll add minus. In the case of a spherical refractive error, when we rotate our axis 90 degrees, it will still appear neutral. Both meridians have the same power and are neutral with the same lens power. So in this case, our retinoscopy is complete. We can write down that spherical power, and there is no cylindrical component. A more complex case would be if you survey the reflex in both primary meridians and you realize the eye has astigmatism. First, you will locate the principal meridians of the patient, and you can do this using the break, skew, intensity, and width of the retinoscopy reflex. If you see with motion, you will add power until neutral motion is observed. When you rotate the axis 90 degrees, one option that may happen is now we see against motion. As we're working in minus cylinder, that means that we have to rule out how much cylinder is involved. So we will set our minus cylinder axis parallel to the against motion reflex. At this point, we have to then add minus power until that motion becomes neutral. Now that we have both of those values written on our power cross and we have the correct axis we know that all meridians are neutral, and that is our endpoint. The other option that may happen as you start to scope the first primary meridian is that you add power in one meridian until neutral is observed, and you rotate your axis 90 degrees, and instead of against motion, we're actually still seeing with motion. That means that you did not start by neutralizing your most plus or least minus meridian. This means that you have to continue to add plus in that meridian until it becomes neutral. When you rotate back 90 degrees, the other principal meridian should now have against motion. Make sure to change your axis to 90 degrees away. Add that minus cylinder power until the against motion becomes neutral, and by then you have met your endpoint. Here is an example of what this may look like on a power cross. Keeping in mind, if you have a 50 centimeter working distance, meaning from your eye to the patient's eye, we have 50 centimeters between our retinoscope and the patient's eye, you must subtract your 2 diopter working distance. If you have a little longer arms, you're a little taller and sit further back, you may need up to 67 centimeters. I recommend this as your working distance because you can easily subtract 1.5 diopters from your retinoscopy findings. In this case, we can look at a lens that was neutralized at 450. And excuse me, these axes are flipped. So the 450 is actually at the 180 axis. Once we've neutralized the 180 degree axis at 450, you can see that we flipped our axis 90 degrees and neutralized the 90 degree axis at plus 1.25. Subtracting our working distance of 2, we end up with a retinoscopy finding of plus 250 and minus 0.75. However, keep in mind that the cylinder is actually the difference between these two meridians. So you have to find the difference between our plus 250 minus 75, which gets us to our final retinoscopy finding of plus 250 minus 325 at 180. And you can see here that we have the gross retinoscopy findings to start. And once we have subtracted our working distance, we have the net retinoscopy finding, which is our final working distance. And we have another poll question here. In this question, you neutralize the 90 degree meridian with a plus 350 lens. You rotate your beam 90 degrees and see against motion. You then neutralize the 180 degree meridian with a plus 225 lens. Your working distance is 50 centimeters. What are your net retinoscopy findings? All right, so a little bit spread out across the board here. However, most did get this one correct. So our answer here is C. Looking at this example, you can see that as we scope and neutralize the 90 degree meridian, we neutralize with plus 350. When we rotate our beam, we neutralize the 180 degree meridian with plus 225. Our most plus meridian is the spherical component. So after taking out a 2 diopter working distance, because we were at 50 centimeters, we end up with plus 150 at our 90 degree meridian on the power cross and plus 0.25 at the 180 degree meridian. Our axis is at 90 because that's our most plus meridian. And then we proceed to find the difference between our two meridians, which is actually a 1.25 diopter difference between those two powers. That gets us our net finding of plus 150 minus 1.25 at axis 90. Some clinical pearls. for retinoscopy include moving your retinoscope faster to make the reflex easier to see. You don't want to slow down and let the patient accommodate through the lenses that you're neutralizing with. Doing very brisk, quick motions actually gets you a much clearer reflex and makes it a lot easier to appreciate whether you're seeing with or against motion. Make sure that we're moving the lenses frequently and avoid scoping that same lens for extended periods of time. Accommodation can actually induce against motion, so we don't want to keep scoping the same lens in front of the eye for too long for fear that the patient might accommodate through it and give us false results. As the far point moves closer to the retinoscope or closer to that neutrality point, the reflex becomes brighter, thicker, and faster. So if your reflex is very dim, very slow, and difficult to appreciate, you can assume that you're likely very far off from neutrality, and you might want to make bigger jumps when you're adding either plus or minus lenses. And if you're at neutral with the sleeve of the retinoscope down, you can also push that up, and you should see neutral motion as well to double check yourself. Pushing the sleeve upwards also allows for a thinner, brighter streak, and sometimes this can help determine the cylinder axis. When you find a neutral reflex, you should be bracketing with plus or minus 50 diopters, and the reflex will be with if you move far past neutral in the minus direction, which is in the less plus direction as well. The reflex will become against if you move past neutral in the plus or less minus direction. This is a good way to check yourself to make sure that even if you've hit neutrality, you can convince yourself that you're not missing any added power because you truly see that reversal. We'll now be moving into manifest or subjective refraction techniques. This is an overview of our phoropter, where you can see variety of knobs. We see our lock knob right up top so that it's nice and stable in front of our patient. One important knob is the PD knob so that we can add in the correct distance between our pupils for our patients and get the most accurate results. We also want to make sure to level the phoropter, looking at the level knob and watching that bubble in the top right corner, making sure that it is directly below that small white dot to indicate that it is level. We have a variety of lenses that we can add in. We have a Risley prism unit for adding prism in front of our patients, as well as our JCC unit. You can see the sphere dial on the right there and also on the left that we can use our hand to shuffle up and down, in addition to our cylinder axis knob and our cylinder power knob. Your exam room setup should include the patient seated comfortably in an exam chair about 10 to 20 feet away from the VA chart. Make sure that that visual acuity chart is calibrated for your exam room distance. You should also project full room illumination, and the phoropter should be placed in front of the patient and leveled. There are a few places that you can start from to put into your phoropter. If they are a previous patient, their previous glasses prescription is a great place to start. For a new patient, you can always use an autorefractor and try to put those findings in. This is less accurate for pediatric patients who are able to accommodate a great amount. So I would recommend starting with your retinoscopy for pediatric patients. You can also put in previous glasses prescription if the patient brought in their lenses and conduct lensometry to find out what they're wearing currently. This is an overview of the steps of manifest refraction, and we'll go through them one by one, keeping in mind for this lecture, we will be talking about minus cylinder. The first step is sphere refinement, where we occlude the patient's other eye. We determine the working visual acuity based on what we've entered into the phoropter. And keep in mind the patient should be at least 20/50 to proceed. We will project a line, 3 lines above their working VA, which is the lowest line of letters that the patient can see through either the retinoscopy findings or their habitual RX in the phoropter. We will fog the patient by adding sphere power plus lenses and plus 0.25 diopter steps. This helps to relax accommodation for the patient. My patient education here is that I will be showing you a series of lenses to refine your glasses prescription. You will let them know we're going to make these letters blurry on purpose. Let me know when they're blurry, but just readable. And one clinical tip is don't forget to occlude the patient's other eye. We want to make sure that this is done monocularly. So always alternate the O for open with the bold line underneath to the right to the OC, which occludes the eye. So if the right eye is open, make sure that left eye, you alternate the knob to OC. You'll then project the working visual acuity line and check that it's blurry for the patient. You'll then unfog the patient or add more minus in 0.25 diopter steps until they can read the smallest line possible. This is done until no improvement and the quantity of letters is achieved. You can attempt a quality quarter, meaning that they may have gotten 5 out of 5 lines on the 2020 line, or 5 out of 5 letters, but when we add in that extra click of minus, they're able to read a lot quicker. They subjectively really appreciate that additional minus. We then move on to cylinder refinement. This is when we introduce the JCC lens in front of the patient and show a single line that's, again, 3 lines above their working VA. If the patient was 20/20, I recommend putting up a 20/40 line. This creates a circle of least confusion that causes images to straddle the retina, which each flip of the dial. One side will produce an image in front of the retina, while the other produces an image behind the retina. The closer that the image gets to the retina is the patient's preferred astigmatic correction. It will appear more clear to the patient as it gets closer and closer to their retina. The goal here is to get the images to look the same as you flip through both of the JCC lenses. If you start with a minus 0.75 diopter of SIL or greater from your RET findings, I recommend jumping straight to axis refinement and then doing a cylinder power refinement. If you have minus 0.5 diopters of SIL or less from your RET findings, I would recommend starting with power refinement, proceeding to your axis refinement, and doing a final power refinement to check. During power refinement, the axis dots on your JCC are aligned. During our axis refinement, you have to twist the knob so that the axis dots on the JCC are straddled. And my clinical tip here is to always end with a power screening. By aligned, you can see here that where the P for power stands, it's aligned with that red dot. The small white arrow is pointing directly to that dot, and we know that we are doing our power refinement. When we switch to axis, you can see here that we alternated the knob so that the arrow is now pointing directly in between both the red and the white dots. We've straddled the axis, and now we know that we can proceed to do our axis refinement. With cylinder refinement, you want to use very clear patient education from the start. You will ask the patient, which of these choices makes the letters more clear? They may both be blurry, but let me know which step is more clear. You want to make sure that if they choose the red dots, that this is adding more minus lens. If they choose the white dot, this is essentially adding plus lenses or less cylinder correction. Acceptance for the patient is when they report that both options look the same or that the red dot option is more clear. Rejection of power is when the patient prefers the white dot option, in which you would remove more power. You'll show them both options until the patient reports they look the same or until they continue with reversal between two options. One clinical tip is that for every 0.5 diopters of SIL that you add, you must remember to add plus 0.25 to your sphere power to compensate. For our axis refinement, you'll orient the JCC in the straddled position, which is 45 degrees on either side of the axis that you found during your retinoscopy, and you'll ask which choice is more clear. we want to chase the red dots here. We call it chasing the red. So when you show them axis 1 versus 2, if they choose axis 1 or choice 1, make sure that you orient your beam in the direction that the red dot is facing. You'll bracket around the preferred axis until the patient reports the same or has a slight reversal and toggles back and forth between two options. With less cell power, you can alternate these axes in bigger increments. With 0.5 to 1 diopter in your cell power, you can make 15-degree changes. As the cylinder power increases, the patient will tolerate less and less change in axis. So I would recommend using only 10-degree changes, and anything over 0.25 diopters or 2.25 diopters of cell, only 5 degrees. Keep in mind some patients may be pickier than others, so remind them that it's okay to say both options look the same. Some patients are very type A and want to get this very precise. They think that there's a right and a wrong answer, but I'll remind you that you are the doctor in control, and if you know that we've been toggling around a similar axis on multiple attempts, it's likely very close to our endpoint, and we can end the axis refinement and do any necessary refinement and trial frame out of the phoropter. You can see here that you'll use your thumb to rotate the dial to show them option 1 or 2. You can see that the cell power is added in that small box. We have 0.75 diopters of cell in there now, and turning the cell power dial on the outside. And to change your axis, you rotate the innermost dial. Right now we're at about axis 30. If the patient preferred a option that was in the direction of a red dot, we would orient towards the red. Our final sphere refinement, once we've completed JCC, is to remove our JCC lens, and you'll now project the 20/20 line. I will again fog the patient or add plus in 0.25 diopter steps, and then slowly reduce those minus diopters until the patient can read the 20/20 line. If additional minus allows the patient to read 20/15 with improved clarity, you can offer a 1 click of minus quality quarter as long as it does not make the letters smaller and darker. You want to verify, does it truly make it clearer or just smaller and bolder? If they report smaller and bolder, you've likely over-minused your patient and should give them back that click of plus. We will then proceed to binocular balance. At this point, we assume that we've completed refraction for the right and the left eye, and we will open both eyes. We are balancing accommodation for the patient here. So this has to be done when visual acuity is equal in both eyes. Two options are prism dissociation in addition to alternate occlusion. Prism dissociation compares our clarity while they're simultaneously viewing two targets. This can induce vertical diplopia since we are adding base down over one eye and base up over the other eye, and they're able to see both options simultaneously. Alternate occlusion is when they compare when the examiner covers one eye at a time and asks them which one is more clear. And I would recommend alternate occlusion if the patient tends to suppress, they're not able to appreciate both of the two images at the same time, or if they're very uncomfortable with the double vision. It is a little dissociating for some patients and it makes some a little bit dizzy. So alternate occlusion is definitely another great option. For our prism binocular balance, you can see here that we added in our Risley prism lenses over both eyes and added 4 prism diopters base up over the right eye and 4 base down over that left eye. The procedure will be to project 3 lines above the working VA, again if they're 20/20, projecting 20/40, and fog both eyes, about 3 clicks of plus. Then you will ask the patient if one line looks more clear than the other. Make sure you tell them it may not look as bright as the other, but focus on which one's specifically more clear. If there's no difference, they can go ahead and remove that prism. If a difference is observed, you'll go ahead and add plus to the clearer eye until they report they're equally blurry or if reversal occurs. Our alternate occlusion is the same procedure. However, we're not adding in the Risley prism lenses. So we'll project a line 3 above their working BA, add about 3 clicks of plus to fog them, and then we alternately cover each eye, asking which is clearer. Here we're covering the right eye. We would then switch to the left, and we would add plus to the eye that the patient reports is more clear. This effectively makes it equally blurry to the eye that they're perceiving that's still a little bit blurry. So be very clear on the language you use. Make sure you are aware whether you're asking them which one looks more clear or which one looks more blurry, because that's going to determine whether you add plus to the right or the left eye. Once we have completed binocular balance, we assume that the patient is still fogged. They still have those plus lenses in place, and we project the 20/20 line. We'll then remove plus or add minus binocularly until they're able to read the 20/20 line with both eyes. Here you can attempt the quality corridor, which I would recommend only doing if they truly subjectively appreciate that extra click of minus. If it just makes it darker and bolder, or they don't notice much of a difference, avoid over minusing them and make sure to go with the most plus endpoint. We have another poll option here regarding binocular balance. During binocular balance, you place 4 prism diopters base down over the patient's right eye and 4 prism diopters base up over the patient's left eye. After fogging the patient, they tell you the bottom image is more clear than the top image. What is your next step? A couple more seconds here. All right, so very evenly split. So the correct answer here is A, add plus 0.25 sphere over the left eye. Keep in mind that when we add prism, the direction of the base is not where the image is. The image is sent up towards the apex of the prism. So when we place 4 base down over the right eye, that right eye is seeing the top image, and our left eye is seeing the bottom image. Since the patient is telling us that the bottom is more clear, that means that we want to fog it further, make it more blurry. And the left eye is seeing that bottom image, so we would go ahead and add plus over that left eye. Our final step of refraction that a lot of examiners forget about is trial frame. In the phoropter, they may be 20/20, but we want our patients to be what we call 20 happy. Do they have not only clear, but comfortable vision? Small changes in cylinder or axis that they prefer in the phoropter might actually appear wavy or distorted in trial frame when they're walking around in a real life scenario. You want to put your phoropter findings in trial frame and have the patient walk around. You can ask about wavy lines, whether walls look distorted, are they experiencing eye strain or headache, and have them go into a hallway, look out a window, and really cause a real life situation for them, because that's how they're going to be walking around with their glasses. You can always add plus or minus 0.25 or 0.50 over each eye, just to make sure that it's still clear and comfortable, or whether they appreciate a small change in that sphere power while in trial frame. You can assess their comfort at multiple working distances as well. I call this the money step. This is the step that we should be taking with every patient to make sure that their glasses not only give them good clear vision, but also very functional vision for their lifestyle. Have the patient view distance objects that are far away. I like either the end of the hallway or even out a window. That'll simulate what it might be like when they're driving or using their glasses looking at very far distances. Intermediate might be a good option for someone who works on a computer often or a laptop. You can have the patient actually sit in front of the computer and demonstrate their true working distance between them and their home computer for you. And then you can trial those lenses to what is optimal and most comfortable for them. I often have patients check their near ad by using their own cell phone because that's something that's very applicable to every day-to-day life, or a book that they would read with a very comfortable print size so that they can show me their own working distance in case it's not exactly at that standard 40 centimeter working distance. Again, 20 happy is what we call a patient who has clear and comfortable vision. This is our end goal for every refraction, and it's up to you to help your patient determine what is most comfortable for them. Even if they're 20/15 in the phoropter with their full cylinder correction, they may feel more comfortable with reduced cyl correction in trial frame, even though they're only seeing 20/20 in both eyes. So you always want to go with what provides the patient the most comfortable vision. And finally, to wrap up, a few thoughts and clinical pearls that I'll leave you with are making sure to use an objective measure of refractive error as a starting point. This can be your autorefractor, a retinoscopy finding, something that lets you know you're very close to their endpoint, and then letting them give their input on that subjective component as another tool. You want to be very clear and use simple language. You want to tell them, I'm going to show you two choices. Neither may be clear. Let me know which one looks more clear. That helps you avoid the patient who just says, both blurry, and you start to lose their responses because they become frustrated. Let them know some choices might be blurry. They might both be blurry. Our goal here is to get the one that is the most clear. And it's okay for them to look the same. A lot of patients think that the same is an incorrect answer, or that they're not going to get the most accurate prescription if they don't tell you one or two. So encourage your patients. Let them know the same is always a good answer, and always remind them that it is a choice before starting your refraction. I would recommend maintaining efficiency by bracketing. If you're toggling between two choices, such as if your patient brings you between 5 degrees, between two axis points, and they say the red's more clear, and then you flip it, and now they like the red in the other direction, and we're just toggling back and forth. It's okay to stop that refraction as the examiner, knowing that you're close to endpoint, and then putting it in trial frame and refining it in real space. Slower responses also mean that you're likely getting close. If they can't tell which one looks significantly more clear, it means that we're very close to our endpoint, and that's a good sign. So stay patient with your patients. You're the doctor, and it's up to you to decide when to move on, and when your patient may be really anxious or not sure what the procedure is. Be patient with them, give them some time to respond, but don't be afraid to say, this is our endpoint. We're going to move on. This is the most clear that my patient has seen. And always remember, you're in charge of the refraction. You ultimately get to decide that final prescription for your patient. You do not always have to prescribe what you end with in the phoropter. It's up to you to determine what provides the most clear and comfortable vision for your patients. That is the end of my presentation. Thank you all for coming out and learning a little bit more about tips and tricks for refracting our patients in the real world. Both are great tools that you can use in a variety of clinical settings, and it really benefits our patients when we know how to get them that best corrected visual acuity. It also helps us know that we have reached their true visual potential and gives us an accurate assessment of how much vision may reduce from other factors like ocular disease. And I will now open up the floor to questions. If you have additional questions following the question session, please feel free to reach out to me. My email is listed here, and I would be happy to discuss more with you. So our first question, can you advise on how an examiner who can only one eye during retinoscopy? I believe that may be referring to if you're not comfortable using your left eye. I would advise becoming very ambidextrous and becoming comfortable with it. It does take practice. So even if you are right eye or left eye dominant, I would advise practice. Unfortunately, retinoscopy is a skill that takes a lot and a lot of practice to really nail down. All right. And we have in retinoscopy, I usually get a half diopter more than the subjective refraction. What might be the reason? So we had a comment that on subjective, they may not accept your full objective amount. That's a great consideration. Again, retinoscopy is a starting point that you can put in the phoropter. And I had a question, what is place on the power cross? And that's what we had gone over in the lecture where you find your meridian, neutralize it, and put that lens power down so you don't forget it. And then you proceed and rotate your axis 90 degrees, and you can put down that value on the power cross. And that's a very efficient way so that you have both the powers that you use to neutralize written down on the correct corresponding meridian. And then we take our working distance out, either 2 diopters or 1.5 diopters subtracted from that, and you can find your net retinoscopy. And I have a great question. Up to what age do we do cycloplegic refraction? Cycloplegic refraction is the gold standard to get the most accurate refractive error, particularly in pediatric patients. It is something that we use for a lot of kiddos, and there's no true answer for when we don't use it. What I tell my students is that if you want to cyclo a patient, you have to explain to me why. So what I will do is assess how old is the patient. Usually before 7 years old, I will cyclo to get an initial assessment of their refractive error. I will make sure that we're not hiding any plus prescription that they're accommodating through. Another indication for cycloplegic refraction is in patients with amblyopia or strabismus, where it's critical that we get the most accurate prescription. Other indications may be a patient symptomatic for eye strain, headaches, a lot of visual symptoms, trouble keeping things clear at near, or intermittent blur. That suggests that there may be a latent hyperopia component or an accommodative dysfunction in which it benefits us to know their full cyclopleged refraction. But again, you can do it on adults as well, provided they are symptomatic and you want to know their true refractive status. I had a question to reiterate 3-eye technique. And that technique is that when you start on the right eye and you proceed to go to the left eye, you want to consider that when you're scoping the left eye, you've already added lenses to our right eye. It's fogged essentially with your working distance. When we move on to the left eye, I'm very confident that that's the accurate prescription because the right eye is very blurry. It's likely not accommodating. What I started though, the left eye could have still influenced by accommodating. So I moved back to my right eye and just double check. So 3-eye technique is essentially a double check to make sure that no accommodation affected your retinoscopy results in that first eye. And we have, what is the procedure of neutralizing one meridian that's neutral while the other has against? So what that would mean is as you're neutralizing your neutral meridian, or I'm assuming you're seeing no lenses, you would write down that it's neutral at 0.0 on that power cross. When you flip to the next axis and you're seeing against motion, you'll add minus lenses until you find neutral again. From that point, consider that you had a working distance involved. So although it appears neutral with no lenses in front of it, it will likely actually be a -2 or -150 diopter finding at that axis when we take out our working distance. So essentially, it's the same procedure. It's just that you have scoped, you've added a little bit of width and a little bit of against, and it's still neutral. So you know that you can write 0.0 on that power cross, and then you want to go ahead and take out that working distance. And we have, does it matter what cycloplegic agent you use? I prefer cyclopentolate in addition to tropicamide so that I get a optimal dilation. For cycloplegia, we recommend 1 drop of cyclopentolate. We wait 5 minutes and add another drop of cyclopentolate for the full cycloplegic effect. In clinic, this may not be something that's attainable if you have a very fast moving clinic. So we will do 1 drop of cyclopentolate, wait 5 minutes and add 1 drop of tropicamide, which gets a very close effect. But ideally, you do want to do the 2 drops of cyclopentolate 5 minutes apart from each other and wait 45 minutes for that optimal cycloplegic effect. And I have a question about the principle of fogging. Fogging is another way to say that we add plus lenses. And what this does is it blurs the patient. It makes things a little bit less sharp so that we take away their accommodation. The purpose of this is to make sure that we don't over minus a patient just because they're accommodating and inducing that minus. And I have a question on in retinoscopy, which meridian will be chosen as a spherical meridian? The spherical meridian, when we are using minus cylinder, is going to be the most plus or least minus meridian that you neutralize. If you scope one meridian and you neutralize with +2, and you scope the opposite meridian and neutralize with +1, that +2 meridian is your spherical. And vice versa, if you keep in mind when we're in minus power, if you neutralize the 180-degree meridian with -1 and neutralize the 90 with -2, that -1 is the least minus and the most plus meridian. So the -1 at 180 would be your spherical. I have a question on the duochrome test for binocular balance. That is the red-green screen. I recommend the duochrome test only when our final subjective refraction monocular visual acuities are not equal. If they are equal, I'll proceed to do prism dissociation or alternate occlusion. If one eye is 20/20 and one eye is 20/25, then I will use that duochrome test. All right, and I have a question. Do you have any tips for a scissor type reflex when doing retinoscopy? Scissoring is very difficult to neutralize. I would recommend really using the upper sleeve, so pushing your sleeve up so it's converging rays to try to get the most accurate axis. But keep in mind, it's very difficult for all examiners, even someone who's very proficient in retinoscopy, to get that reflex neutralized. So I would go in big brackets until you 100% see reversal, and you can bracket from there. And ideally, you would put that in trial frame and then do a very close subjective refraction for your patient to make sure that you have the optimal axis that gives them the best visual acuity. I have a question. Do we always need to give full correction of cycloplegic refraction always? I would argue no. Very rarely do we give the full cycloplegic refraction. The cycloplegic refraction is a tool so that we may find their optimal, their full refractive error, and then we can cut equally, keeping the aniso between both eyes. This will help us in a case where we scope a patient who is +1 in both eyes on their dry ret. When we cyclo, they may have a full +4 that we reveal once accommodation is knocked out. I would likely not prescribe that full +4 unless there was another medical indication, such as an esotropia, where that would benefit the patient's eye alignment. I would cut and likely give them +2 or +3 so that we can really relieve that demand on the eyes, but they'll still be clear and still wear the glasses. So subjective refraction with the cyclopentolate in both eyes is very beneficial. And I have a comment. I have a challenge doing cyclo on children with cerebral palsy. What would be your comment on doing dry ret? I would recommend doing a dry ret in a very dark, wide-spaced area and finding an engaging target, such as a video or something that the patient will likely enjoy watching far away. So you want to make sure that we have a very far distance target so that we're not inducing accommodation. And loose lenses help here as well, so that we don't distract our patient. You can definitely do retinoscopy with the ret bars, but you can also take loose lenses and just throw them right in front of the patient's eyes and work your way up that way. So we have during retinoscopy, a true neutral glow is sometimes not able to be obtained, and a slight degree of movement is seen. This is a great question because this goes into what I call bracketing. When we are scoping and you see very slight width, I would recommend throwing in even more plus. So you want to throw in even more plus way past that neutrality point until you 100% clearly get that reversal into against. From that point, you know at this amount of power, I'm at against. I've gone too far. And then you slowly work your way back down until you get that high neutral glow. You may see that very slight movement. So I would recommend putting in the most amount of plus power or least minus until reversal. I think that's a very good technique to really convince yourself that you are seeing the most accurate refractive error. Throw in a little bit extra at the end on to make sure that we're actually getting that true reversal. And we have before starting cross-sil on subjective, do you subtract the sphere by 0.25 for the circle of least confusion and then return it once it's complete? So with our cross-sil, if we add in our whatever we scope on red is what we put into our cylinder power. While on subjective, if we add more, so say that the patient accepts the red, we add more minus, and then we show them two options and they choose the red again, we add more minus in the cylinder power, then we proceed to add plus 0.25. If the patient then reverses and chooses the white, and we take out a quarter diopter, remember to take away that 0.25. So you will only do that during the subjective refraction, keeping in mind that for every 0.5 of sil you add plus 0.25, and for every 0.5 diopters of sil you take away during the subjective, you have to add minus 0.25. How do you make retinoscopy easy in a jerky eye, such as nystagmus? Great question. We have a lot of patients who will have nystagmus and their eyes are constantly roving. I would recommend using a high plus lens in front of the eyes. This is the same for when we take visual acuity. You want to use a frosted lens, not a full occlusive lens. I would recommend taking a +5 over their habitual correction over one eye to try to slow that eye down and then go and do your ret from that point. So I have a comment. Many problems occur during refraction. What are major things to consider during refraction of a low vision patient? This is a good question because it brings in our retinoscopy and our trial frame refraction and how essential those are. Low vision patients benefit from a trial frame refraction, doing it in free space, and I would recommend using very big jumps. So you want to make sure that you are using lenses that have the patient's just noticeable difference. So if they're a low vision patient, we're probably not showing them, which is clear, plus 0.25 minus 0.25. They're not going to appreciate that difference. You want to find what they're able to notice during the refraction. So when you're doing it, you may actually show them +1 and then -1 over what they have in the trial frame. So you're going to be making a lot bigger jumps so that they're able to notice and appreciate those differences. For manifest refraction, you mentioned that we should start with axis refinement for about 0.75 cylinder or higher that they have an astigmatism. Is that a different process than the normal? So to clarify on this, this is referring to starting with either the power or the axis refinement with the JCC in place. When we have less than 0.75 diopters of SIL, I like to double check the power first. So I will show them which is clear 1 or 2, and I'll have my red and white dots aligned with the power. Once they have hit their endpoint, either they look the same or they've reversing between the two options, I'll switch to do axis. And then once I refine my axis, since I don't anticipate any big changes, since it's a lot harder for someone with a very small amount of SIL to notice axis changes, I'll go back and do a power refinement. The contrary is when they have more SIL or they're going to notice an axis change a lot easier. Someone with -3 diopters of SIL is going to notice even a 1 or 2 diopter or 1 or 2 degree axis change. I go straight to axis to make sure that we can get the best axis lined up first, and then I'll move into power from there. And that's just because if the axis is very far off from your ret and they have a high amount of cylinder power, it's a lot easier to get your axis all squared away first so that they're able to appreciate the difference during the power refinement and give you the most accurate responses. How reliable is the autorefractor in determining the power of the lens in cycloplegic refraction? The autorefractor is a good starting tool, particularly in adults. I tell my students, do not use your autorefractor in any kiddo or anyone 16 and under who is not cyclopleged. Accommodation is at play, and you're going to get very inaccurate results, often very over-minused. So I will often use the autorefractor as a tool once the child has been cyclopleged, and I always trust my ret. So I will say, they got a decent amount of cylinder and this axis on the auto. I'm finding something very similar. So let's see how both of those come into play when I do my cycloplegic subjective refraction in trial frame. But I would definitely trust my ret over an autorefractor, particularly on a pediatric patient. We have a comment. What do you do if the new prescription glasses make the patient have a headache or get nauseous? What is wrong? This is something that can happen when we forget the trial frame step. This is why I call the trial frame that money step. You want to make sure that the patient is comfortable. It sounds like we did the refraction to phoropter here, finalized the full prescription and sent them on their way. With the trial frame, we're able to make sure that in free space, the patient really appreciates that cylinder correction in that axis. They may get distortion if the axis is not at their favorite subjective placement in the phoropter, so we can change that in the trial frame. So any astigmatism with the axis that's off or too much cylinder power can induce symptoms of headache or eye strain. That's again why we also double check with plus or minus 50 in our trial frame, the sphere power to make sure that that's what they prefer in free space as well. If you did do trial frame and they're still feeling nauseous, I would recommend looking at the glasses modality and checking things like the pupillary diameter, making sure that the glasses are aligned with their optical center, and consulting with an optician if you have any questions on the way that the glasses were made and how they're fitting the patient. And we have, if the person does not have distance correction, but has a need for near up to 1 to 2 meters to watch TV, what changes will be in refraction, or will there be other modifications? So that's something that you would have the patient demonstrate in office. So keep in mind as we get closer to a target in a presbyope, we're going to need more plus in that prescription. So you would likely want to have the patient, if they're being symptomatic with the distance glasses you're giving them, I would recommend having them go home and measure the distance from their couch to the TV so that you can simulate that in office and trial the most appropriate lens for them. And we have, what are pearls for refraction more difficult or more uncooperative than a normal neurotypical pediatric patient? For this case, we call it get in and get out. Keep in mind that you are the examiner. The patient came to see you, and it is our job to engage the patients for testing. What I would recommend is putting on a video that they like. We'll bring in our own phones and put on Mickey Mouse or a video that's very soothing or calming. Ask the patient's parent what they enjoy, what they watch at home. You can have the child sit in their parent's lap to be a little bit more comfortable and just give them some time. So don't jump right into throwing all these lenses in front of them. Let them watch the video a little bit, and I'll just scope my lens in front of their eyes so they get used to it and just scope it again. And eventually I'll go in with a loose lens and get one sweep, and I slowly work my way up. So it does take a little bit of time, but you want to modify your exam room to fit the patient and help them feel most comfortable. And we have, when is the Jackson cross cylinder necessary to do? This is for any patient who has cylinder or needs additional correction. So if you do scope sphere on your retinoscopy, I would challenge you to what we call fish for sill in the phoropter. So I would do the Jackson cross cylinder essentially on every patient. And what you do is, even if you have zero cylinder power that you were scoping with your retinoscopy, put in plus or minus 0.5 diopters of sill in the JCC and show them all four primary meridians. So ask them which is more clear, 1 or 2 at axis 180. If they choose the white or a rejection, take it out and move to axis 45. Ask them which is better, 1 or 2. If they choose white, it's a rejection, move to axis 90. And so on, you go to axis 135, and then you've shown that you've shown them cylinder correction at all the primary principal meridians, and they rejected it every time. In some cases, they may actually accept it, in which case you proceed with your full Jackson Cross Sill procedure. And I have, why are we getting an error overcorrected with high myopia in phoropter? Especially in pediatric patients, consider that the phoropter is coming closer and closer to our eyes. That's going to induce that proximal accommodation, and that drives the patients into that accommodative status, which can give us a false overestimation of minus. We know that myopes love minus. They will accept and accept and accept, which is why I like showing my most plus retinoscopy to the patient and then slowly working them down. Even if they accept -2 and I'm scoping -1, that tells me that the patient truly does not require that full -2 refractive error, and I will do everything I can to fog them and slowly work them down by adding minus until they first see that 20/20 line. So try not to continue to over minus that patient. And if you are getting over minus results in the phoropter, try putting your retinoscopy findings in a trial frame, and that will induce less of that proximal accommodation for the patient. And we say, what about in the case of over or under correction? How do we know if they're over or under corrected? And that would be following our cycloplegic refraction. You always want to make sure that if you are unsure or things aren't making sense, that you do that cycloplegic refraction, and that will let you, with your retinoscope, find their true refractive status. You know that what you're seeing is the true reflex and the true most accurate refractive error, and you don't need any input from the patient to do that. And that's how you can determine whether they were over or uncorrected in the past, and then show them that in trial frame and slowly work with them to find the optimal prescription that they're able to tolerate. Is it better to have the patient fogged or occluded when refining cyl and axis? I recommend occluding the other eye so that we can do one at a time. However, when we do the binocular balance, you do want both eyes open, and at that point you would fog them so that we take out any accommodation that may be residual in that patient, and that will get you a more accurate result during that binocular accommodative balance. How much should we subtract after cycloplegia? Again, that depends on our patient and the findings that we get. With pediatric patients, if they have an esotropia or esoposture, I do recommend pushing for full plus if they can tolerate it. From there, you will slowly reduce the plus prescription until the patient subjectively is able to see their best corrected visual acuity. So there is a subjective component for our older kiddos, but with our younger ones who may not have any other comorbidities, just a 5-year-old patient who has 4 diopters of cycloplegia, I will often take away about 1 to 2 diopters, depending on how much they're able to tolerate following subjective. In a patient with any accommodative dysfunction, I will prescribe the amount of plus that takes their MEM or monocular estimate method findings from a lag of accommodation into the normal range. And that's another technique that you can use to figure out how much plus you should actually be prescribing. Should the examiner wear his spec correction for doing the retinoscopy? Yes, examiner should be fully corrected, and then you'll just place the retinoscope right at the plane of your spectacle lens as well. Is binocular balancing done for all patients, including amblyopic and geriatric patients? Binocular balancing is only done when both visual acuities are equal between both eyes. So in an amblyopic patient, we would anticipate, especially in an ISO amblyope, that one eye would be more reduced and we would not be able to complete that binocular balance. So that is a good thought there. Why do we have to make the patient see 3 lines above the working VA? Why not the same or just one? The thing about JCC is that it's very hard for the patient to appreciate a difference if we're at threshold. We recommend 3 above their working VA to make those letters a little bit larger so that as we show them the 2 options, they're able to appreciate the difference, and it makes it a little easier for the patient to give you more accurate feedback. Versus if they are sitting at their threshold, it may be just blurry enough that they're not able to appreciate the difference and we don't get as accurate of results. What is the best tip in the case where the RX is trialed but still brings discomfort to the patient? Again, I would recommend talking with your optician or considering how the glasses are fitting them. You want to also make sure that you closely assess the patient's habitual working distance. If you prescribe glasses for near and the patient's attempting to use them for an intermediate distance, such as their laptop, they may not have brought that up to you at your exam. So I would recommend really sitting down and asking, what do you use these glasses for, so that you can modify them to bring the most comfort for the patient. How do we adjust the post-cycloplegic correction? And how much do we increase or decrease the sphere compared to the refraction before cycloplegia? So the post-cycloplegic correction is the same procedure as a trial frame refraction, just post our cyclodrop. So it can only be done at distance since we'll be blurry at near. But I will likely put in the retinoscopy findings that I find post cycloplegia and then repeat that refraction. The dry refraction is a starting point, but the most accurate is the cycloplegic retinoscopy. And then you proceed to put that in trial frame and find where the patient subjectively is most comfortable. In the case of very, very young kids, you would ideally prescribe the full cylinder and the axis that you scope yourself on the cycloplegic retinoscopy. And then I would cut plus equally between both eyes. So make sure that you keep the aniso when you're cutting for any pediatric patient. If the cylinder changes from negative to positive after cycloplegia, how do you prescribe? So cylinder is either negative and minus sil, or when we talk about plus sil, that is actually what the ophthalmologists typically use. With optometrists, we use minus sil in our phoropter because that's more applicable to glasses and creating them and based on refractive data. However, plus sil is more common in ophthalmology due to its surgical implications. Both of them create the same type of prescription. You just have to transpose between the two. So I wouldn't expect that the minus cylinder would change to plus. It would likely need to be transposed into plus cylinder, but they would still have that same amount of cylinder. If you do notice a change, even if it's not necessarily from minus sil to no sil, you are able to prescribe that for your patient. They may reject the cylinder post cyclo and truly be spherical, and that's dependent on what you're scoping on your patient. Do we have any other methods for refining cylinder power and axis other than the straddling method? In the phoropter, that is the only method. We do have loose lens Jackson cross sills for low vision trial frame refraction available if you want to try it in trial frame. However, it's a very similar concept that you'll be showing the patient. Another option would be using your retinoscope, getting your objective measure and showing it to the patient in trial frame and seeing how they feel with that in the trial frame. And someone asked, what is the primary difference between subjective refraction and retinoscopy? Primary difference is that one is a subjective measure. The patient gives you input. They can answer and tell you which ones look more clear. Whereas retinoscopy is completely objective. You do not need your patient to give you any feedback to complete that test, which is why it's very good with young kiddos, especially doing it in a 1 or 2 year old who you know will likely not give you any feedback. They don't know their letters, they may not be ready to match yet, but you as the examiner can use your retinoscope and get their refractive correction by neutralizing that reflex. Whereas in subjective, the patient's able to give you a little more input and you will be able to really nail down their exact subjective prescription by doing that. And would you give tips on retinoscopy over previous glasses? What would be expected and what would be taken off from the prescription? So this is what we call our over refraction. Ideally, if they had an accurate refraction before, I would expect to see with motion immediately, and my working distance is 50 centimeters, so I'd expect to neutralize with about a +2. If we are scoping more or less, you would ideally have to write down your over refraction findings, and then you will combine the two and put that into a trial frame so that you can do a more accurate subjective refraction. And what you would expect to see really depends on whether the patient requires more spherical correction, more cylindrical correction. Sometimes the axis is not correct, in which case I will typically take off the patient's glasses and do a retinoscopy just with the patient and their true refractive error alone. And another question on binocular balancing. If a patient has -250 sphere in both eyes and -8 in the other eye with no history of glasses, how should we do binocular balancing? This would depend on the final visual acuity of the patient. So again, binocular balancing can only be done when the final visual acuity is equal between the both eyes. There may be some degree of unequal best corrected visual acuity with this patient. And someone commented that we could do contact lenses for the NISO, which I definitely agree with. Don't forget about that option for your patients as well, that we want to reduce that anisoconia they may be experiencing with those different image sizes. So I would definitely think that would be a great contact lens candidate. And we have, if a patient has a headache and they accept plano, but after cycloplegic refraction shows plus, what do we prescribe? And that's a very common scenario. That's a case where a patient may be symptomatic, headaches, eye strain, and we cyclo them because we're not sure why they're experiencing these, and it reveals this extra plus power that they are accommodating and focusing through. What I would recommend is demonstrating that plus power for near vision only glasses. Since the accommodative demand is so much greater at near, they'll likely find a lot of relief from near vision glasses with that low plus prescription to help with their symptoms. Just being very clear with them that they will take them off for distance or they'll likely be blurry. If they don't want to take glasses on and off, what you could do is a plano distance lens and create a bifocal for them so that they look through the no correction portion at distance and then that plus portion at near. Yep. All right. I think that is it. That's our hand for time. So that is all the time we have for questions today. And it has been a pleasure to give this talk to all of you and discuss different strategies for refracting our patients. I hope that you took some of these clinical pearls away and will be able to apply them in clinic.